Good evening, Dr. Shailesh, Dr. Srijit, uh, respected teachers, my dear friends. First of all, I thank the Calicut Gut Club for giving me the opportunity to talk on this very common issue of cystic neoplasm of pancreas. So, when we practice as surgeons or gastroenterologists or physician, cystic neoplasm or cystic lesions are a very frequent encounter on imaging, but it represents only less than 10% of pancreatic neoplasm, and it may present with varied clinical and imaging presentation, and they have a wide range of prognostic and treatment implications. So, to some extent, the imaging studies help us to come to a conclusion, but in a minority of cases, they remain indeterminate. So, cystic neoplasm pancreas usually present as incidental detection in 2.6% of all abdominal multi-detector CTs. And in MRI, the rate is a little higher, to the tune of 2.4 to 20%. And as age advances, the incidence increases up to 40% in patients above the age of 70 years. So we call it a cystic neoplasm for all those cysts which possess a true epithelial lining. So the key issues which we have to address is how to differentiate cystic neoplasm from pseudocyst, selection of a diagnostic imaging, role of endoscopic ultrasound, prediction of malignant behavior, what is the role of surgery in the management of cystic neoplasm, what is the management of incidental cyst, and how to follow up these patients. So the classification of cystic lesions of pancreas, they are basically classified as epithelial cystic lesions and non-epithelial cystic lesions. The list is very containing so many conditions, of which the important ones will be discussed in this session. So there are many associations put forward guidelines, but good guidelines should address the key issues. One will be which cyst need follow-up, and what interval, and which imaging modality, and what are the worrisome features, and what should prompt us further investigation, or what is the role of surgery, and after surgery, what is the imaging which used for follow-up and all. But there is no ideal guideline for managing the cystic neoplasm. But there are many guidelines put forward for managing the intraductal papillary neoplasm of pancreas. So the prediction of malignancy, there are some tumors which has got malignant potential, and there are some tumors which are usually benign. The malignant potential will be therefore the mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, and solid pseudopapillary neoplasm, and cystic islet cell tumor. Whereas the serous cystadenoma and lymphoepithelial cysts are almost always benign. So this differentiation between tumors with malignant potential from those which is always benign is very important when you plan the treatment. So morphologically, the cystic pancreatic lesions can be classified into 4 types. One is the unilocular cyst. Second is a macrocyst with multiple septae. Third is a microcyst, multiple microcysts, and sometimes they will show a scar. And lastly, a cyst with the solid components or mural nodules. Among these, the unilocular cyst is the most commonly seen in pseudocyst. The macrocyst most commonly as a part of mucinous cystic neoplasm, microcyst usually in serous cystadenoma, and the cyst with solid component is part of MC and mucinous cystic neoplasm, or in intraductal papillary mucinous neoplasm. So what is the role of major imaging modality, which include the ultrasound, CT, and MR? It is used for detection. It is used for characterization. It is used for assessing the aggressive behavior of the cyst, and for evaluation of resectability of a tumor which is already harboring a malignancy. So a CT scan, a multi-detector CT with a pancreatic protocol, is ideal for initial evaluation of pancreatic cystic neoplasm. It has got an accuracy for lesion characterization in the tune of 56% to 85%. And the characteristics are better, characterization are better for lesions more than 3 centimeter. And it is also highly sensitive for detecting calcification, which is part of some of the cystic neoplasms like serous cystadenoma and mucinous cystic neoplasm. And it aid in the evaluation of aggressive features like solid nodules, thick septations, and thickened walls. And it has got a high accuracy in differentiating aggressive pancreatic cystic neoplasm from benign lesions into the tune of 63.4% to 73%. And it is useful for staging malignant pancreatic cystic neoplasm up to 90%. So when there is aggressive behavior, CT has got a better predictability, and the tumors less than 3 centimeter, the characterization is not that good. So MRI is more sensitive for pancreatic cystic neoplasm. It is superior to CT in analyzing morphologic features like internal septations, mural nodularity, and communication with pancreatic duct. And it has got a high soft tissue resolution, and it lacks the ionizing radiation. But MRI has got some disadvantages like poor spatial resolution. We are not very good at reading MRI, but we are good at reading CT. And there is a very low sensitivity for calcification, and the MRI is susceptible for motion artifacts. So the next comes the role of endoscopic ultrasound, which is widely available nowadays. It is a very sensitive tool for assessing the cystic neoplasms, and it will help to identify the high-risk features like thick internal septations, mural nodules, solid masses, pancreatic duct dilatation. It is comparable to MRI in identifying ductal communication. It will show the filling defect in main pancreatic duct, which is very well seen in patient with intraductal papillary mucinous neoplasm. It will also help you to identify the vascular invasion, stage the local extent of the tumor. And if you do EUS-FNA, it is ideal for tissue diagnosis. So EUS is beneficial if there is a confusion between a microcystic serous cystic neoplasm and pancreatic neuroendocrine tumor. So when there is a lesion in the pancreas which is not very large, and when they are all having small microcysts, the wall of the cyst will be enhanced by the contrast enhanced CT. And when you look at it, it may behave like a pancreatic neuroendocrine tumor. So the differentiation is very important because serous cystadenoma doesn't require any surgical intervention. It is helpful in differentiating microcystic solid serous cystic neoplasm from MCN, which is again very important because the serous cystic neoplasm doesn't require any surgical intervention. It also helps to differentiate chronic pancreatitis with pseudocyst from main duct IPMN. And if there is a lesion more than 3 centimeter in branch duct IPMN, US is very helpful. And when you have solitary lesions or multifocal cyst in a pancreas where there is a high risk stigmata on CT or MR, US is better imaging or better in assessing the lesion. So when you aspirate the cyst fluid, the analysis will help you to come to a diagnosis in most of the cases. If it is a serous cystadenoma, the viscosity will be low, amylase will be variable, CEA will be low, glycogen will be there because it contains cuboidal epithelium rich in glycogen. The mucinous cystadenoma shows high viscosity, variable amylase level, high CEA level, and mucin content. Sorry. So IPMN, because of the ductal communication, there will be a high amylase level, and since it is a mucin containing tumor, it will be high in CEA. And pseudocyst, there will be low viscosity, but amylase will be high, CEA will be low, and cytology will show only inflammatory cells. So if you see some nodules on EUS, they are all showing the risk of advanced pathology. if you do endoscopic ultrasound, around 3% of branch duct IPMN will show a low or intermediate grade dysplasia. But if you do it for branch duct IPMN with high grade dysplasia, 60% will show these sort of nodules. But not all nodules are precancerous. Mural nodules detected on CT or MRI has got a 9-fold risk of advanced pathology. But if you see it on EUS, it has only 3-fold risk of advanced pathology because EUS is more sensitive in detecting the mural nodules. There are some drawbacks of EUS. It is invasive, complication rate 2.4%, highly operator dependent, and when you have a larger cystic lesion, there is rapid loss of resolution with increasing depth. So cyst more than 5 centimeters, the characterization may be difficult by using endoscopic ultrasound. There are some emerging methods of diagnosis. If you know the diagnostic tools for pancreatic cystic neoplasm, only around 1/3 of pancreatic cystic neoplasms can be accurately diagnosed by CT or MR, looking at the characteristics. The remaining 2/3 will require endoscopic ultrasound guided aspiration, and some of them still require the biomarkers for better characterization and diagnosis. So there are so many biomarkers available which are based on DNA, RNA, or protein. The DNA-based biomarkers include the KRAS, GNS, and VHL. RNA-based include the microRNA 21, microRNA 216 and 217. There are protein-based biomarkers like MUC1, MUC5AC, or VGFA, which is seen in serous cystic neoplasm. So the biomarkers can be based on diagnostic genes, or some of it will be having prognostic implications as well. So coming back to the cystic neoplasms, it is very important to differentiate pseudocyst from cystic neoplasm, because the current strategy for managing pseudocyst is the conservative line of approach. No need of any intervention if the pseudocyst is asymptomatic, where there is no increase in size, where there is no ductal communication, or where there is no associated malignancy. Whereas cystic neoplasm, when there is mucinous type of lesion, you may require surgical intervention or resection. So when you consider pseudocyst, they will have a history of pancreatitis or trauma, and it lacks an epithelial lining. If you have a patient with pseudocyst where there is no episode of pancreatitis, suspect a cystic neoplasm. So even in some of the adenocarcinoma, when there is a ductal obstruction in the pancreas, the patient can have focal pancreatitis distal to the area of tumor, and they may develop pseudocyst. So an underlying malignant pathology, malignant tumor is possible, especially if you treat patients with this chronic calcific pancreatitis. That may be an indication of an underlying malignancy. So you have to be very careful in leaving those patients by conservative method. So pseudocyst lacks an epithelial lining, and there will be normal serum tumor markers, and the cyst fluid is having a very low viscosity, and there will be elevated serum amylase. So the picture shows a pseudocyst on a background of chronic calcific pancreatitis. It can very well be misdiagnosed as a mucinous cystic neoplasm with a peripheral eggshell calcification, because that is a malignant tumor which has got a malignant potential. The second the issue is the actual serous cystic neoplasm. The serous cystic neoplasms are mainly seen in females, usually around 60, 70 years, and they are known as the grandmother lesions. They are all non-mucinous without much malignant potential, and they are distributed throughout the pancreas. The previous textbooks are all showing serous cystic neoplasm as the most common cystic tumor of pancreas. Now there is a change in the distribution and the type of lesions, because the branch duct IPMN is being diagnosed more commonly now. Most of the tumors are less than 4 centimeter, and it is one of the specific tumors seen in patients with von Hippel-Lindau disease. There will be multiple serous cystoadenoma. And there will be pancreatic duct dilatation or communication. But some of the serous cystic neoplasm may compress on the bile duct or pancreatic duct and may present as pancreatic duct dilatation. We have seen patients presenting with please, can you unmute? Can you mute the? Okay. So no pancreatic dilatation or communication, and typically more than 6 is with a size 2 millimeter to 2 centimeter. And you can see a central calcified scar in 1/3 of cases. And the growth of this tumor is always less than 1 centimeter per year. So there are two major variants. One is the microcystic or the polycystic variant, where there are very small cysts clubbed together forming the actual tumor. They have a lobulated appearance, and it is lined by a PAS positive glycogen-rich cuboidal epithelium. The second variant is the problem because it has got a larger cyst, which may be misdiagnosed as mucinous cystic neoplasm and seen in around 20%. And they are seen in younger age group compared to the microcystic variant. So the differentiation from mucinous cystic neoplasm is very important in the oligocystic variant of serous cystic neoplasm. So imaging will show enhancing wall, internal septae, microcystic appearance, lobulated border, honeycomb appearance, and the differential diagnosis is a neuroendocrine tumor of pancreas because of the enhancement pattern. So if you do a high quality CT, it may show the honeycomb appearance, sunburst calcification, central stellate scar. And if you do MRI, they will show hyperintense cyst on T2 weighted images. And if you do EUS, that will show the multiple small microcyst, and the cyst aspiration will characteristically show a low viscosity fluid with a low CEA and a high VEGF level. So what is the indication for surgery in serous cystic neoplasm? All symptomatic serous cystadenoma has to be resected. When the tumor size is more than 4 centimeter, if it is in body tail region, it is easy to resect and resection may be carried. But if it is occurring on the head region, if you are very sure that it is serous cystic neoplasm, you can observe those patients till they develop some symptoms. When you have an uncertain diagnosis between serous cystic neoplasm and other type of pancreatic tumor, you have to do resection. And when there is a rapid growth, while you observe the patient, when the growth is more than twice or more than 1.5 times the actual size during observation, you have to consider malignant tumor, or your diagnosis may be different. Or when the radiograph shows a substantial change in appearance during observation, you have to resect. So this is a nutshell about serous cystic neoplasm. These are the imaging features, and this is the cut section of the tumor showing the honeycomb appearance and the cuboidal epithelium, which are glycogen rich. The second very important tumors are the mucin producing cystic neoplasm. Basically, there are two types. One is the mucinous cystic neoplasm, or MCN. The other is intraductal papillary mucinous neoplasm. Both are pre-malignant condition, and both require some sort of surgical resections. So mucinous cystadenoma usually occurs in the middle-aged women, usually seen in around 40 to 50 years. They may become large cysts without much symptoms, and mostly seen in around 90% of women, and only 10% is seen in male. If you see a mucinous cystic neoplasm in the male patient, you have to think of alternate diagnosis. And it is having a pre-malignant feature or a malignant feature. Around 6 to 48% of asymptomatic lesion at the time of diagnosis may have cancer. So mucinous cystic neoplasm, you have to manage aggressively. The distribution is mainly in the body and tail region, because since the distribution is in the body tail, the surgical resection is easier compared to the head region. Usually it will show a unilocular macrocyst with septations, and the wall may show some calcifications, but there is no communication between the pancreatic duct and the lesion. That is the finding which differentiates the IPMN from mucinous cystic neoplasm. So you have a thick, round, thick wall separated cyst without any ductal communication. There will be a characteristic ovarian type of stroma in mucinous cystic neoplasm, and they are all lined by mucin producing high columnar epithelium, long columnar cells. Based on the epithelial dysplasia, they are divided into adenoma, borderline tumor, and the carcinoma. So the imaging will show a unilocular or separated or a macrocystic appearance. Sometimes there will be curvilineal calcification or peripheral eggshell calcification. If you have a lesion more than 5 centimeters showing a peripheral calcification, the chances of harboring an aggressive behavior or a malignancy is very high. So there are potentially heterogeneous cyst contents, and the presence of thick enhancing mural nodules, one has to consider the possibility of a malignant mucinous cystic neoplasm. So the cyst fluid will be having a high viscous fluid. If you see the aspiration, it may show something known as the string sign because of its high viscosity. They may form some globule-like thing. And they're all paucicellular, and there will be characteristically high CEA level. If you consider the CEA value of more than 192 nanogram per ml, it is 73% sensitive, 84% specific, and 79% accurate for differentiating mucinous tumor from non-mucinous tumor. If you see KRAS mutation, it is around 20% of low-grade MCN may show KRAS mutation, but if you do it for high-grade MCN or invasive, it will be to the tune of 90%. But characteristically, the GNAS mutation is not seen in patients with MCN, which is a specific mutation seen in patients with IPMN. So the treatment of mucinous cystic neoplasm is resection. Even if there is adjacent organ involvement like spleen, colon, or stomach, it may be resected along with the specimen. If there is a non-invasive or early invasive tumor arising in a cystic neoplasm, they have a better outcome than the corresponding pancreatic ductal adenocarcinoma. So after resection, some of these tumor patients may develop recurrence. A close follow-up is actually indicated in these patients. You never try an enucleation in a patient suspected of mucinous cystic neoplasm. So this is the in nutshell about mucinous cystic neoplasm occurring predominantly in females of 40s and 50s, and you have to do a resection always. The next variant of mucinous neoplasm is intraductal papillary mucinous neoplasm, which is first described by Ohashi in 1982. It is characterized by papillary proliferation of mucin-producing epithelial cells with excessive mucin production that may actually float in the pancreatic duct or in the main pancreatic duct or in the side branch. Majority of them are seen in men around 60 to 70 years. So if you consider pancreatic neoplasm, only tumor which is predominantly seen in men is intraductal papillary mucinous neoplasm. Basically, there are 3 types described. One is the main duct type, characterized by dilatation of main pancreatic duct more than of 5 millimeter, which may be diffuse or segmental together with the atrophy of the pancreas. The branch duct IPMN characteristically will show multifocal cysts in clusters, just like bunch of grapes, with mild or no dilatation of main pancreatic duct. And mixed type, where there is the involvement of the parenchymal duct as well as the main pancreatic duct. If you consider the malignant behavior of intraductal papillary mucinous neoplasm, the main duct type and mixed type behave almost similarly, whereas branch duct type has got a low malignant potential. So MRI is better than CT in diagnosing IPMN because it is helpful in diagnosing the ductal communication, identifying the mural nodule, and it will actually help to exclude alternate neoplasm. And if you see an enhancing mural nodularity or septations, they all shows the aggressive behavior. And if there is a mural nodule more than 5 millimeter, there is a high likelihood of high-grade dysplasia or invasive cancer. So you aspirate the cyst and look for mucin CEA of more than 192 nanogram per ml. There will be more than 80% will show KRAS in main duct IPMN, and GNAS mutation is seen only in main duct IPMN, that too of intestinal type. So there are 4 distinct histologic types. One is the intestinal, second is gastric, third is pancreatobiliary, and fourth is oncocytic. Among these, intestinal and oncocytic has got a better prognosis. So if this IPMN turned out to be a malignant type, the intestinal and oncocytic will become a colloid carcinoma, whereas the gastric and pancreatobiliary will form a tubular carcinoma. The colloid carcinoma has got a better outcome than the tubular carcinoma. So the prognosis of IPMN depends upon the histologic type, whether it is intestinal type or whether it is the pancreatobiliary type. So if you see a T1 invasive with an N0 status carcinoma arising in intraductal papillary mucinous neoplasm, they have a better survival than the de novo adenocarcinoma. But if the stage migrates to T2 and T4, or when there is nodal metastasis, the same prognosis is that of de novo carcinoma of pancreas. So I already mentioned the carcinoma arising from intestinal and oncocytic variants has got a better outcome. So this is in a nutshell about the images of IPMN. You can see the CT scan cross-sectional imaging show diffuse dilatation of pancreatic duct. The next picture shows a branch duct IPMN. The second picture shows a main duct IPMN. And last picture shows a mixed IPMN. So the main duct IPMN, the problem is you cannot clearly differentiate a tumor from the dilated pancreatic duct. So the surgical resection is extremely difficult sometimes to get a negative margin. So what about the malignancy in main duct IPMN? If you see all the published literature, you can see around 70% of patients with main duct IPMN harbors carcinoma in situ and 43% having invasive malignancy. But if you consider malignancy in branch duct IPMN, the rate will be around 25% carcinoma in situ and around 15% of invasive carcinoma. So it is always not mandatory to resect all patients with branch duct IPMN. So there were many guidelines put forward like Sendai guideline, Fukuoka guideline, and modified Fukuoka guideline for managing patients with MCN and the branch duct IPMNs. So what is the treatment for main duct IPMN? The surgical resection is the mainstay of treatment, and it is more technically demanding. What is the rationale of resection? It is to ameliorate symptoms, remove all high-risk lesions, and to potentially cure invasive lesion if it is already there. There are some groups who put forward the observational approach even for the main duct IPMN. When the patient is having a high surgical risk or when there is a competing life-terminating condition, including another malignancy, never try to do a pancreatic resection. You can always observe. But in some patients with a low risk main duct IPMN, where the ductal dimension is only 5 mm without any mural nodule, some group has put forward the observational management, but it is not very well accepted. So what is the method of resection in main duct IPMN? It's a very challenging strategy because of the diffuse dilatation without a mass. If there is a definite tumor, we can always resect it with a negative margin. So the treatment, the surgical resection has to be individualized depending upon the type of lesion. And the reason for ductal dilatation may be tumor spread along the duct, or it can very well be the thick mucin, or it can be due to associated chronic pancreatitis. The distinction is very difficult sometimes. So the involvement of main pancreatic duct can range from a very small focal involvement to a diffuse involvement with skip lesion. So if you resect without any frozen section, you may sometimes miss the invasive cancer or the lesion with high-grade dysplasia. So most common surgery done for a main duct IPMN is pancreatoduodenectomy, followed by distal pancreatectomy, and finally total pancreatectomy. The total pancreatectomy most of the time occurs after a pancreatoduodenectomy, where you do frozen section and the resection margin become positive for invasive carcinoma or high-grade dysplasia. If you have a Carcinoma in main duct IPMN, you have to consider standard lymphadenectomy just like the other pancreatic carcinoma. So what is the role of frozen section? You can have microscopic extension of neoplastic cells beyond the visible boundaries of main lesion. So it is a very common occurrence in main duct IPMN, or it can be a multifocal with a margin very well involved at the time of initial resection. So if you get a positive margin like high-grade dysplasia or invasive carcinoma, you have to resect more, what is known as a creepic resection of the pancreas. If there is low-grade dysplasia or intermediate-grade dysplasia, you can very well follow up this patient to avoid the morbidity of a total pancreatectomy. So after resection of main duct IPMN, you have to put forward the surveillance strategy because there is a chance of recurrence in the remaining pancreas, and there may be development of branch duct IPMN, or patient may develop high-grade dysplasia in the remaining pancreas. So there is some sort of a cancerization developing in patients with IPMN. So you have to closely follow up these patients. But the issue is the imaging strategies which is recommended for as per the guidelines is very costly, which most of the developing countries can't afford. So that is the only issue. So you can do MRI or EUS depending upon the availability. But if you have a main duct IPMN where there is only low-grade dysplasia or intermediate-grade dysplasia, and after surgical margin, if there is a negative margin, you need to follow up using CT 2 years and 5 years. But if there is a positive margin, you have to do 6-monthly MRI. And if there is development of a lesion, you can very well go and resect. So what is the importance of doing this surveillance strategy? Because the outcome or prognosis of tumors detected on follow-up is very good compared to the de novo pancreatic cancer. So what about the branch duct IPMN? So the branch duct IPMN, the risk of malignancy is less, but there are some high-risk stigmata of malignancy described, like obstructive jaundice occurring in a patient with a cystic lesion in the head of pancreas, or enhancing solid nodule in a cyst or a mural nodule. So that is an indication for doing resection in branch duct IPMN. And there are some worrisome features described, like pancreatitis, cyst more than 3 centimeter, thickened or enhancing walls, non-enhancing mural nodule, abrupt change in caliber of pancreatic duct with the distal atrophy, or elevation of tumor marker like CA19N. These are all worrisome features in branch duct IPMN. So there is a revised Fukuoka guideline put forward for managing branch duct IPMN. So if there is high risk stigmata, go and resect. If there is no high risk stigmata, if there is any of the following worrisome feature, you have to do an endoscopic ultrasound, define the mural nodule. If they are more than 5 mm, do resection. If they are less than 5 mm and the size of largest cyst is less than 3 centimeter, you can observe. It is more than 3 centimeter, you resect. This is the revised guideline put forward by the Fukuoka consensus. So even after branch duct IPMN, you need to do the surveillance strategy, because the malignancy developing in branch duct IPMN and main duct IPMN has got almost the same characteristics as the adenocarcinoma pancreas. And after resection, the remaining pancreas may develop cyst, or they may develop adenocarcinoma. So you have to do the follow-up like main duct IPMN. So if the margin of resection is negative, you can observe, or you can wait for 2 years and then do 5 years. But if it is positive, you have to do follow-up imaging every 6 months. So these are the main cystic neoplasm. The next tumor which I'm going to discuss is not a true cystic neoplasm. It is called a solid pseudopapillary epithelial neoplasm. So it is a very rare tumor as per literature, but it is very commonly seen in tertiary care center, because most of them occurs in the head region of pancreas and proximal body region, where the resection is very tricky. So it represents 10%, less than 10% of cystic neoplasm, and it first described in 1959. But the characterizations are all done in late 80s. And it is classically seen in women in their 30s, and majority of them are only, the patients are only women, because there is some involvement of the progesterone receptors described in patients with solid pseudopapillary neoplasm. Basically, solid pseudopapillary neoplasm are solid lesions. When there is increasing size of the lesion, some of it become necrosed, there will be liquefaction. And when you image this lesion, you may see something like a papillae. So they are known as the pseudopapillae. They are not true papillae as you see in intraductal papillary mucinous neoplasm. So solid pseudopapillary tumor has got a malignant potential, and some consider it as a tumor with a low-grade malignancy, because you have no criteria for diagnosing malignancy just by seeing the local nature of the tumor. The metastasis is the only criteria by which you can diagnose a malignant SPEN. But if you look at the perineural invasion, angioinvasion, or adjacent tissue invasion, there may be there may not be actual invasion. There may be some inflammatory adhesions only. But around 10%, 5 to 10% of patients may have metastasis at the time of presentation. So we have done Whipples for more than 16 patients with the SPEN ahead of pancreas. But only recently we saw a patient where there is a large lesion. It was a 20-year-old female. On initial imaging, there was a single liver met in the segment 7. So we did the primary resection of the cystic lesion, and the liver lesion has to be aggressively treated because their prognosis is very good. So we are planning for that. So when you do MRA, MRA will show these sort of pseudopapillae because of the necrosis of solid tissues, and there will be a T2 hyperintense lesion when there is a cyst component. So this is another patient in which I operated this patient, diagnosed to have a large SPEN in the body tail region when she was 6 months pregnant. So she was having pain, so we decided to do a resection immediately. And you can see the image showing the tumor in the upper part and fetus in the lower part. And finally, we did a distal pancreatectomy, splenectomy. And after the delivery, they sent the photo of this child. And that patient is doing well. So solid pseudopapillary neoplasm is seen in young patients. This is in nutshell about solid pseudopapillary neoplasm. The characteristic gene which is described is beta-catenin gene mutation, which is almost specific for SPEN tumors. So the next variant is called the cystic pancreatic endocrine neoplasm. Around 8% of resected pancreatic cyst is represented by this group of tumor, and majority of them are non-functional and mainly seen in the MEN type of patients. So when you have an MEN syndrome and when you see pancreatic tumor, exclude the possibility of a cystic neuroendocrine tumor. So CT will show a cystic lesion with hypervascular rim and occasional septa, and which may contain solid component. And there will be high cellular yield compared to other cystic lesion. The cystic neuroendocrine tumor will give you high cellular yield, and there will be very low CEL level. So the differentiation from mucinous cystic neoplasm is easier. So this is one patient whom there was a large cystic lesion in the body tail region. We were suspecting some cystic tumor like solid pseudopapillary neoplasm. This patient was just 2 months postpartum. So we suggested resection, but they went for some homeo treatment, and finally she is diagnosed to have a neuroendocrine tumor, and she died of recurrence. So the next variant of cystic lesion is the lymphoepithelial cyst. It is one of the rarest of cystic neoplasm, and it is seen mostly in men. And it is evenly distributed. Even though it is very rarely seen, sometimes it can be symptomatic. The treatment of lymphoepithelial cyst is almost like a pseudocyst where you can just drain it into the jejunum or into the stomach because there is no malignant transformation described. So after this, we'll consider what are the surgical options in cystic neoplasm. So depending upon the location of cyst, we can consider various surgical procedures. So if you know the approaches, there are 3 approaches for all surgeries now. One is open approach, second is laparoscopic approach, and third is robotic approach. Depending upon the availability of expertise, we can use any of these approaches. But doing laparoscopy for the head lesions may be a little difficult. But nowadays, the distal pancreatectomy, the standard procedure is laparoscopy, especially the lesion size is smaller. You can very well do a laparoscopic distal pancreatectomy with splenectomy or without splenectomy. So this is a 2 patient. These are all surgical images from my own patient. You can see a large mucinous cystic neoplasm in the body tail region. We resected. The other one was the large serous cystic neoplasm, which was resected by distal pancreatectomy. The other surgery is a pancreatoduodenectomy. This was a solid pseudopapillary tumor at the head of pancreas. You can see this images showing a compression on the main portal vein and superior mesenteric vein portal vein junction. But majority of these cases, during dissection, we can very well separate the tumor from the portal vein. So it is not mandatory to do portal vein resection in patients with a solid pseudopapillary neoplasm if you can actually separate the lesion from the veins. So this is one patient whom we did a pancreatoduodenectomy for a spen. So this is another patient in whom we did a total pancreatectomy. It was a mucinous cystic neoplasm, almost completely occupying the pancreas. She is still alive without any issues. So there are some organ preserving approaches described, because when you do surgery for IPMN, you may have multiple lesions, and if you continue to resect, the patient will not have pancreas. It may be amount to a total pancreatectomy. So there are many procedures described like enucleation, central pancreatectomy, spleen preserving distal pancreatectomy, duodenum preserving pancreatic head resection. And there may be other procedures like inferior head resection and middle preserving pancreas. The almost all procedures are possible, but most of them are very demanding procedures. Enucleation as a treatment is advised only for patients with serous cystic neoplasm or some branch duct IPMN. And it may be a treatment in a neuroendocrine tumor like insulinoma where there is no risk of malignancy. But the problem is, it is technically easier, but there is a high incidence of pancreatic fistula when there is very close communication with the main pancreatic duct. The second procedure described is a median pancreatectomy. This is to the 1 week back picture. You can see a lesion in the exactly at the neck of pancreas. If you do a distal pancreatectomy, this patient will lose a large amount of pancreatic parenchyma, may develop diabetes. So we thought of doing what is called a median pancreatectomy, where the tumor-bearing segment of pancreas is resected with a margin, and the distal segment is anastomosed to jejunum, just like we do after a Whipple's. So there is other procedure. This is again a serous cystic neoplasm, which is symptomatic, and you can see the pancreatic duct is dilated. So in some serous cystic neoplasm, we can see a dilated pancreatic duct. And this patient underwent duodenum preserving pancreatic head resection. Surprisingly, this patient had a meningioma in the spinal canal. So in the post-op period, this patient developed paraplegia. So we did a resection of the spinal canal meningioma in the same city. So this patient is again alive after 7 years of surgery. So this is the middle preserving pancreatectomy, especially indicated in patients with branch duct IPMN, where you resect the proximal part of pancreas and distal part of pancreas. The middle part of pancreas is preserved with its blood supply. But it's a very demanding surgery, not possible by the most of the routine surgeons. So coming to the algorithm for management of cystic lesions in the pancreas, when there is a unilacular cyst, you exclude the possibility of a pseudocyst. If there is no pancreatitis and if there is no increase in amylase, consider the alternative diagnosis. When the patient is asymptomatic, management depends upon many factors, including the fluid analysis. If the patient is systematic, consider a resection, surgery, or drainage of the cyst, depending upon the situation. But if it's a neoplastic cyst, resection is always indicated. If it is a microcyst, the patient having a serous cystadenoma, they're asymptomatic, you can do imaging and follow up. If patient is symptomatic, do surgery. There is a cyst with a solid component, exclude the possibility of malignant neoplasm. If it is a malignant tumor, do resection. If it is a SPEN, do resection. If it is a neuroendocrine tumor, do resection. So cyst with solid component, there is only one treatment, resection. If there is a macrocyst, exclude oligocystic or macrocystic serous cystic neoplasm. If the patient is asymptomatic, you can observe. If it is a mucinous neoplasm, if it is IPM and dilated main duct, you do resection. If it is a branch duct IPMN, it is asymptomatic, the size is less than 2 centimeter, you can always observe with the image. So this is in nutshell about management of cystic pancreatic tumor. So there is another entity known as pancreatic incidentaloma, which is actually a lesion detected during an imaging study done for symptoms other than the ones of the mass itself or the organ affected. So this is first described by Ho and Kosti in 2001. So this is a very important issue when we send patients for imaging. When we send for a gallstone imaging or when you send for urinary tract imaging, they may come with a report saying that there is a lesion in the pancreas. So that will actually bother us in regarding the management. So there are three types of incidentaloma. One is called the imaging incidentaloma. Second is called endoscopic incidentaloma, because when you do EUS, sometimes you may see this lesion. And third is called the biochemical incidentaloma. They are all representing the neuroendocrine type of tumors. So it actually represents around 6% to 23% of pancreatic resection for any cause, incidentaloma. So it is an important issue. And if you do a serial or the axial imaging, there is already mentioned, there will be around 1.2 to 2.6% incidence of cystic lesions. And majority of these are detected while you investigate for genitourinary complaint, chest pain, or screening for cancer surveillance test, etc. So there were many studies described the incidence of pancreatic cyst. This is about 24,000 CT scan and MR scan over 8-year period. They have reported an incidence of 1.2% of pancreatic incidental cysts. So the prevalence of cyst in patients undergoing MRI, this is very high because it has got a higher sensitivity than CT for detecting smaller lesions. So what is the clinical significance of pancreatic incidentaloma? The distribution is almost similar to symptomatic tumors. The incidence of malignancy is around 30%. And significantly higher proportion of cases occur in a lower TNM level. So if you identify these lesions, if you do resection, they have a better outcome than those with symptomatic tumors. So when you see cystic lesions, you have to answer the following questions. Is it a cystic neoplasm? Could this lesion be malignant or harbor malignant potential, and does it need to be resected? So all these issues has to be addressed while you see these lesions. So that is very important as far as management is concerned. So this is an algorithm for managing cystic pancreatic incidentaloma. If it is a unilocular cyst more than 3 centimeter, do resection. If it is less than 3 centimeter showing benign pattern, you observe. If there is increase in size over observation, do resection. If there is suspicious pattern, do EUS, FNA. If it is mucinous tumor, do resection. Non-mucinous, you can observe. If it is a microcystic lesion, like a serous cystic tumor, if it's a benign pattern, you can observe. If there is suspicious pattern, do EUS and FNA. If shows mucinous tumor, do surgery. Non-mucinous, do observation. If it is a macrocystic lesion, you have to consider resection, because most of the time they have a mucinous component. If it is a macrocystic variant of serous cystic neoplasm, you can always observe. And if it shows a solid and cystic lesion, do resection. So this is the American Gastroenterology Association guideline for managing cystic pancreatic incidentaloma. So if there is a symptomatic lesion, if at least 2 of the following high-risk features seen on MRI. So you have to do an MRI in all patients with a cystic lesion of pancreas as per the American Gastroenterology guideline. And you have to repeat imaging if you have the policy of observation. If you resect this patient, if it shows some high-risk behavior or invasive cancer, you have to plan a follow-up strategy as well. So the cystic neoplasm pancreas is not a very simple issue. It has got a very important management concern as far as a gastroenterologist or a gastrosurgeon or a general surgeon is concerned. So to sum up, the cystic neoplasm pancreas varies widely in clinical behavior. You have to apply your clinical sense and use all the available investigations to differentiate a pseudocyst from cystic neoplasm. EUS is a very valuable adjunct in patients with cystic lesions, and you have to use EUS appropriately. Never use EUS for all patients with cystic lesion where your CT is showing a characteristic of a serous cystic neoplasm, or you can very well exclude an aggressive tumor. You have to avoid unnecessary resection because there are many conditions in which the course is entirely benign, or you have a long time of benign pathology before they develop a malignancy. So always try to preserve the pancreas when you consider resection. Avoid total pancreatectomy if you can avoid it by using frozen section strategy in patients with IPMN. Thank you for your patience here.
Thank you, Pradhavan, Dr. Pradhavan, for the wonderful presentation. We have discussed almost every aspect of cystic neoplasm of pancreas, and the topic is open for discussion. Any questions? We have discussed about the organ preservation strategies in this cystic neoplasm surgery.
Yes.
And one of the important things is in the distal pancreatomy, preservation of the spleen and splenic artery and splenic vein.
Okay.
You have mentioned that, and my question is, this is the most commonly employed in cystic neoplasm of pancreas. So in which all cases, preoperatively, you think it is not possible? It's not safe to do this organ preservation?
Organ preservation in the sense, if you want to preserve the spleen, if you know the strategy, there are 2 methods of doing spleen preservation. One is the classical washer's technique, where you depend on the short gastric circulation, and the other is just to preserve the splenic artery and vein. But the issue is Kimura's technique. So if you know there is infiltration, or if the tumor is having solid component, trying to preserve the splenic artery and vein by keeping some tissues is very, very dangerous. So if your lesion is going to have a very benign course, like a serous cystic neoplasm, or even a spen with a very well preserved planes, you can try these things, or even neuroendocrine tumor.
What about mucinous? Mucinous without any fluid lesion?
No, if there is no involvement of splenic artery and splenic vein, or if you can have a very clear circulation through the short gastrics and left gastroepiploic, you can consider spleen preservation. But there is always a risk of developing isolated gastric varices if you do those techniques.
Dr. Pradhavan,
Yes, sir.
By definition, when you say this is microcystic, when you say it is macrocystic?
No, cyst size, the size 2 mm to 2 centimeter, it is called microcyst. When the size of the lesion more than 3 centimeter, they call it as macrocyst. Between 2 and 3 centimeter, there is a gray zone.
Right. Okay. So more than 3 is called macrocyst. And I think if the take-home message will be all maybe serous cystadenoma and lymphoepithelial are benign.
observe.
Others you should suspect and do so.
Even in mucinous cystic neoplasm, when you do the follow-up strategy, some of them will develop high-risk behavior. So it is very costly to do the follow-up investigation of all these patients. Doing MRI every 6 months is very costly, which is not affordable to our population. So if the patient is young, fit, and if it is possible to resect the lesion with the safety, I think always use the strategy of resection, even if you are dealing with a branch duct IPM. That is my take.
Nice. It was a nice talk, very interesting talk, especially surgical specimens and surgeries.
Sir,
Ravan, very good talk.
Sir, thank you.
Excellent talk. I just put in a question regarding the median pancreatectomy, like the organ preservation surgery. Will it be safe to leave the proximal part just closed, leaving it for the duodenal drainage? You said the distal part is...
Sir, no. When you do it for a chronic pancreatitis or IPMN type of tumor, where there is a dilated pancreatic duct, it is very risky. But if you do it for a SPEN, where there is no ductal dilatation, and most of the time, if you do a distal pancreatectomy, we will just stapler the proximal end. We will just do a stapling of the proximal end and oversew it. And that strategy is done. The risk is you are having another anastomosis where there is a chance of leak. That is the only issue, rather than closing the proximal length.
Okay. Very well done. Very well done. Good. Congrats. I'll take it.
Dr. Pradhavan, I am Dr. Varghese here.
Thank you, sir.
As usual, a nice talk with a lot of illustrations. Okay, I have one doubt. When we do EUS, sometimes we have come across a small cystic lesion, which is well within the pancreas, and we have doubts whether it is IPMN or actually an intrapancreatic pseudocyst. And there won't be any calcification. And some ductal changes will be here and there because of chronic pancreatitis, but not yet evolved into calcification. So is there any clue by which we can say with the definite, but definitely we can say whether it is
if the lesion is less than 2 centimeter size, if there are no other lesions like mural nodules or any high-risk picture, I think there is no point in differentiating these two. Less than 2 centimeter size. If it is more than 2 centimeter size, and if you suspect pancreatic pseudocyst or chronic pseudocyst, you can always observe because patient may not be that symptomatic. But mucinous lesion, if you suspect, you have to do EUS.
No, but in any case, both are technically benign and small in size. So probably
you can observe.
Observe would be an ideal thing, no?
The mucinous cystic neoplasm, in my experience, less than 3 centimeter, I have never seen a malignant tumor in a mucinous cystic MCN, not IPMN, MCN, less than 3 centimeter. But if it is IPMN, any size tumor, any size lesion can harbor malignancy. That is the basic problem.
Okay, thank you.
Any other questions from the audience?
I think gastroenterologists should have doubts, no? Because they are diagnosing it and sending to us. Because we are having a lot of lesions referred by the gastroenterologist. It's not like the other lesions which we pick. The pancreatic cystic lesions are always diagnosed and sent to us by the gastroenterologist.
Our problem will be once we diagnose and once we detect people with EUS may try to do EUS of NA and try to characterize this by various things. As you rightly said, the string test which can be done at patient bedside itself or during endoscopy use itself. And of course, amylase, CA72 was done sometime earlier, and cytology and other things. So once that is done, and if you show that it is inflammatory, generally we don't send to you unless it's too big and requires some surgery. But most of the other tumors, to be on the safe side, we send. Probably serous cystadenoma is the one thing which is so simple to diagnose because it's very tiny and multiple cysts. Too many cysts will be there, and therefore one will not make a mistake. So all other things, I think, we better refer to surgeon and allow the surgeon to take a decision. That will be wiser on the part of the physician to do like that.
The general saying that the serous cystadenoma is grandmother, the mucinous is
mother and daughter.
Spen
is daughter.
Which is daughter. Spen. Spen is daughter.
Spen. Around 30% of Spen occurs in less than 19 years or in the pediatric age group. I have operated a girl at the age of 12 years. Now she is a teacher. And I did a duodenum preserving head resection. Without much issue, she survived. And now her pancreas is almost okay and no diabetes. So I think Spen, if you do complete resection, they have a high survival, long-term survival, better than MCN, I think.
But Spen is the majority are malignant or?
Sir, now there is a tendency to call it as a low-grade malignancy because if you see the cellularity, they are all highly cellular tumor, but no behavior which is consistently able to diagnose the metastasis or malignant behavior. So if there is a proven metastasis, you can call it as a malignant.
Malignant, yeah. Right.
Dr. Pradhavan, I have one more doubt. I have seen a case of von Hippel-Lindau with serous, multiple serous lesions or multiple cystic lesions of the pancreas, but the entire pancreas seems to have been affected with thousands of cysts. Is that pattern the usual pattern of serous cystadenoma, or is there a specific pattern for von Hippel-Lindau?
Von Hippel-Lindau mutation, what is called the LOH and 3P deletion, etc., are very specifically seen in serous cystadenoma. In fact, there are two tumors seen in von Hippel-Lindau. I have operated a girl because of a neuroendocrine tumor on a background of von Hippel-Lindau. If you can exclude a neuroendocrine tumor by US, by some means, you can always observe those patients because they may have mild symptoms because of the cyst or some hemorrhage into the cyst. Other than that, I think that's a common pattern in von Hippel-Lindau.
Okay.
I did Whipples for her because of that neuroendocrine tumor.
Okay.
Sir, can I ask a question?
Yes.
Sir? Sitara here. Yeah, I just wanted to ask you, what is your experience like in patients? In which set of patients have you seen recurrence after surgery? Like which of these cystic neoplasms recur?
No, I have not seen a recurrence after a benign cystic lesions like serous cystadenoma or solid pseudopapillary lesion. But I have seen two patients who recurred. Both of them underwent some form of enucleation or margin positive resection. One was a solid pseudopapillary lesion, the other was a mucinous cystic neoplasm. But when I look back at the pathology of MCN, that was showing borderline pathology, not the benign pathology. So we have resected pancreatic solid cyst with adjacent organ, including colon, stomach, and all, but no recurrence. But if you do an enucleation type of procedure for a patient with MCN or IPMN, you can have recurrence.
Okay, so it's not recommended.
Not recommended. You do resection with a positive, negative margins. That is the recommended. And if you do surgery for IPMN, the negative margin they recommended is without invasive cancer or high-grade dysplasia, not low-grade dysplasia, because dysplasia will be there throughout the pancreatic duct.
Suppose these cystic neoplasms are on a background of chronic pancreatitis. Is it common?
No, that is very because nowadays there is a group of patients in whom IPMN develop with coexisting chronic pancreatitis. So previously we had a tendency to do conservative strategy or do observation for all chronic pancreatitis when they are not symptomatic. But now there is a catch. Some of this chronic pancreatitis patient is having IPMN type of tumor, and they may develop pancreatic adenocarcinoma without the actual chronic calcium pancreatitis developing a head mass. So the duct may develop cancer, which we may miss. So that is a problem. So you have to exclude the IPMN by studying the mucin. Okay.
I have one more doubt. Have you ever come across adult polycystic kidney disease along with polycystic disease of the pancreas?
One patient I have seen, all cysts, including cysts in the lungs.
Okay, but it seems to be benign only. You don't have to do much.
Only benign, but they are all diabetic because there is no islet. There won't be any islet cells. The entire pancreas will be cysts only. So the high incidence of diabetes in those patients when they are completely replaced by cysts.
Okay.
Regarding the recurrence, I think the most important thing is the histology. In mucinous cystic neoplasm, if the histology is malignant, and then there is a very high chance of, just like an adenocarcinoma of pancreas. We had a patient with mucinous cystic neoplasm. This patient had an invasive adenocarcinoma, and this patient had recurrence in the liver after 2 years after the surgery. So this patient had chemotherapy postoperatively, but still she had recurrence. So mucinous cystic carcinoma, if it becomes histology, is very important in mucinous cystic neoplasm.
Negative margin resection is very important when you consider a mucinous tumor. Margin has to be negative.